Hey there, everybody. Thank you for joining us today. My name is Shane. I run the events over at 10 Capital Network. And again, we have another great one for you today with Dr. Reade De Leacy and Hyprevention. So I'm going to bring our CEO, Hall Martin, up to get us started. But before I do that, just want to remind everybody in the audience, if you do have a question, you can go ahead and put those in our chat box. And don't forget to answer the poll at the very end of the event. Thank you. And Hall, let's get it started.
Great. Thanks, Shane. And I want to thank everybody for joining us today. We will welcome Hyprevention, Cecile Vianney, if she could come on. She's the CEO of the company, and we will hear a presentation from her. Thank you for joining us today, Cecile. If you could introduce our special guest and what he's going to talk about, we'll go ahead and kick off and go from there.
Sure. Thank you, Hall. So I'm Cecile Vianney, the CEO and co-founder of Hyprevention, and I'm pleased to introduce Dr. Reade De Leacy, who is our expert today and who is going to talk about what happened in the field of vertebral fracture, because at Hyprevention we have developed a product to address vertebral fracture, and Dr. De Leacy highly contribute to the assessment of our product. And so Reade, if you're ready to go through your presentation. Thank you very much.
Happy to. Thank you for the introduction, Cecile. Let me share my screen and I'll give you a little bit of background about me. So I'm a neurointerventional radiologist and the director of the Neurointerventional Spine Program at Mount Sinai Hospital in New York. I'm going to talk a little bit about trends in vertebral fracture treatment, specifically around implants and Hyprevention, which is an implant used to treat compression fractures of the spine. And these can either be osteoporotic, traumatic, or related to cancer. A little bit, just, I guess, running over a bit of a background on vertebral compression fractures and why they're important and why we need to be looking at them and treating them. But they're incredibly common. You know, we're an aging population. Osteoporosis is an epidemic. And currently, based on the most recent figures from about 5 to 10 years ago, there's 1.4 million cases of vertebral fractures annually in the United States alone. They do pose a significant burden on the healthcare system with an immense stress in terms of hospitalizations. And that stress is compounded by undertreatment of these kind of injuries, not getting them to interventional surgical treatment more promptly, which means that patients linger in the hospital for longer and they represent to the hospital with issues of pain and pressure sores and the like. We touch on that a little bit next. So VCFs result in poor quality of life, acute and chronic pain, decreased physical and functional performance. There are really very significant negative psychosocial consequences for these elderly patients where they become quite withdrawn. And there's a threefold increase in mortality or near-time mortality in these patients in the coming months to year. And non-surgical management has been associated with double risk of future fractures compared to augmentation. And that really comes down to trying to arrest the deformity that happens when you get a compression fracture. Deformity in the spine leads to abnormal stresses on the adjacent bones, and that can lead to increased rates of adjacent level fracture. I think that in the last few years at least, there's a trend towards us being more involved in treating more of these patients, and that's largely due to evidence-based medicine and trials coming out showing that the interventions we have are better in many cases than medical management. But also, I think it highlights a little bit that we have some imperfect tools to fix what is really, really complex functional problems and mechanical problems in the spine. So our toolkit needs to get a little bit bigger. And I think that implants for vertebral compression fractures is key to that. So VCFs, like we said, mainly due to osteoporosis, so weakening of the bone with aging or cancer. You can get fractures at single or multiple levels, and adjacent fractures are frequently observed in these patients. And I'd say in any 12-month period of the 100 to 150 patients that we see per year coming through, somewhere in the order of 30%, give or take 10%, will represent in the next 3 to 6 months with adjacent level fractures. And what everything is looking towards in terms of moving the field forwards, in terms of procedural technique, but also devices, is ways to arrest and prevent this representation of patients with further fractures. So there's a real focus on novel devices to do that. And some other companies have brought devices to the market, and they're a significant leap forward in the tools that we have. But like any kind of toolkit, there's no one thing that's perfect for every job. So you have to choose the right device or tool for the right fracture. And I think we're getting much smarter at how we approach these fractures and use the right device for them specifically. These are the different techniques that we have. They run from something called vertebroplasty, where a needle's introduced to the bone and you just inject cement. So that's what you see on the bottom right-hand side. Balloon kyphoplasty, which has been around for over 2 decades, which is on the bottom left-hand side, where you see a balloon introduced to the vertebrae and replace that cavity with bone cement. And that's in an attempt to stretch the vertebral body out to its normal size. The drawback really with balloon kyphoplasty is once you put the balloon down, the vertebrae will often just sink down to its normal size as well. Onto curette-based kyphoplasty, the top right is a device from Stryker used to create a space within the vertebrae. You place it down the needle into the bone. And then instrumented vertebral augmentation, and their devices like the Kiva at the top left-hand side, which is a threaded device that actually comes out made of a plastic polymer. And as you deploy it, more and more of these loops are deployed, which are intended to stretch the vertebrae out to a normal shape. It's not used diffusely or significant really within the interventional space for a number of reasons. It's good for certain kinds of fractures, but it's not really a broadly applicable device. Spine jack, which came out a number of years ago now, that's in the middle left pane, which looks like a small car jack. Use that to stretch the vertebral body out, similar to a balloon, but the device stays in the vertebrae and you fill cement around the cavities. And then the V-strut device, which is in the middle right pane, and these are transpedicular, again, plastic or PEEK polymer implants. And the smart thing about this device is that one of the issues that we see in terms of refracture at the same level or adjacent fracture is where the bone is set well in this anterior cube kind of area with cement, but it's still very weak through the attachment to the back side of the spine. And that's where these PEEK or plastic polymers bridge that area to help that phenomenon. In terms of the data and why I think things are starting to turn a quarter and we're going to see a higher volume of patients treated. This is just a busy slide, but it's color-coded, and these are all the prospective randomized controlled trials. So the highest quality data that we have in evidence-based medicine. And these are the studies where yellow indicates trials where either the primary or the secondary endpoints were positive. So they're the things that you set out at the beginning of the trial to investigate and prove or disprove. So there's a preponderance towards these studies generally being positive. There have been 3 that have been negative for both primary and secondary outcomes, and the most notable of these are the 2 at the top in grey from 2009, which has since been down-regulated in their quality of evidence due to issues with methodology. Also, within the last 6 months and in the last 2 to 3 months, there's another randomized study. This is called Vertos 5 out of the Netherlands. And this is looking at intervention for these patients with fractures that are chronic and aged out to 12 months. So greater than 3 months of age. So old fractures, which really, if you're thinking about it, should have a much, much less likely idea or chance of benefiting from surgery or treatment. But interestingly, and is really nicely well-run trial, this is the pain response. So VAS is a visual analog score in terms of pain, comparing the dotted line, which is the control. So these are patients that didn't have a vertebroplasty, but just had some local anesthetic put in, and they were blinded to the procedure versus the treatment vertebroplasty, and there's a significant improvement and difference in pain response. And again, another thing, QALIFO, which is a multi-questionnaire quality of life outcome scale that we use in spine surgery and other kinds of pain-related outcome interventions, and both showing significant benefit for intervention. So it just goes to my point in the general gestalt of the field that things are tending to trend towards intervention, and intervention at multiple time points being better than medical management for lots of reasons. So just a couple of cases to show you how we use the device. I've used this device for up to 2 years. And my relationship with Hyprevention is that I do some consulting, but I also have a industry-funded research grant, which I proposed to the company to run a prospective clinical trial. Because the thing that really plagues me in my practice is trying to make sure that these patients don't come back with future fractures. And any kind of device or procedure or technique that moves that needle, I think is so incredibly valuable for what is, essentially thousands and thousands of patients. So these are some CAT scans on a patient. You see on the left-hand side, a normal vertebrae looks like a nice cube and there shouldn't be any kind of crack running through it. But if you could see my cursor, the fourth vertebrae up from the bottom, there's a big crack, and the one above that, it's flattened a little bit. So this patient had 2 fractures. And again, on the MRI, what you like to see is nice homogeneous color within each bone. And if you don't have homogeneous color, then you've got to explain why. And in this patient, there are 2 fractures. So this is an example of treating with a balloon at one level. And this is what the Hyprevention or the V-strut device looks like implanted before the cement is injected. And that's after the cement is injected. This is a reconstruction of a CAT scan. And this is the patient's 3-month follow-up, which shows, the cement is nicely positioned around the device. You inject cement through the device to keep it nice and steady within the vertebrae. And you could think of it analogous to rebar and cement and building, and no adjacent level fractures. There are new techniques and products that aren't available, and everybody's trying to figure out a way to solve this problem. And that can either be novel cements that are more biomimetic, so cements that mimic normal bone more than PMMA. PMMA is the standard product that we use, which is very, very hard. And if you can think of putting granite next to sandstone, occasionally that's going to wear away and cause a fracture or break that sandstone. And the sandstone is the analogous component to the osteoporotic bone. So Agnavos is a company that's producing a more biomimetic cement, which is going to be very interesting in terms of its clinical trial outcomes. And another device from a German company called VCFix as an amber implant, which has only just recently had its first clinical case. I think that there's no experience or data yet. So this is more where I come in. So I have a post-market registry of all the cases that we've done so far in the United States for up to 38 patients, of which 25 or 26 have adequate quality follow-up for us to publish and talk a little bit about. And what we're really trying to find out is, does this device and does this cement result in the expected response in terms of pain that we typically see with kyphoplasty? And so far it does. But also we're trying to figure out is, does this patient group have a better or similar or worse rate of adjacent level fractures or breakdown at the level that we've treated compared to the predicate devices being balloon kyphoplasty or spine jack or the like. And it's very, very early on, but the data that we have that we're looking to publish very soon is very interesting, and it certainly raises the very, very reasonable question about doing larger, more prospective trials, because the rates of adjacent level fractures are really, really quite low, much lower than I've expected or seen in my practice. So it's interesting. It also has an indication for cancer. So again, this is just to paint a little bit of a picture of where we are in terms of the incidence of cancer patients at the moment within the US and how often bony disease is seen. So up to 2 million Americans diagnosed each year with cancer, and we're living longer, and the oncologic treatments in terms of adjuvant treatments, so medications, radiotherapy, immunotherapy is getting better and better. And a lot of these patients are being managed longer and longer, but up to 80% of cancer patients will develop bony disease, and this bony disease can lead to fractures, or it can threaten things like the spinal cord or spinal nerves. 10% develop these symptomatic spinal metastases, either from fracture or high calcium or compression on neural structures. So intervention for neoplastic disease is also becoming more common and more accepted and more complementary to the other physicians that work in the same field, be them oncologists or radiation oncologists. And I think it's becoming more of an accepted phenomenon that we all do things complementarily to help patients in the long run. And what's important is, radiation for cancer is the mainstay, especially with bony disease, but it's variable in terms of the response to radiation. Some cancers are well known not to respond, and some only partially respond. And if you think of that 1.9 million patients with cancer and 10% of them developing spinal mets that are symptomatic. In 2021, there was only a little bit over 7,000 tumor ablation procedures for all bones in the US based on Medicare data. And that's a massive discrepancy in the amount of patients with the symptomatic disease and those being treated. So I think there's a very, very large horizon of patients and volume of patients that are not being treated that will end up being treated as more data comes through. And as we talked about, spinal related events are common in patients with bone cancer, and these are the things that we're looking to fix and treat. And again, with these patients, what we talked about, radiotherapy is only variably effective. It's an essential adjunctive treatment, but it's not a carte blanche that it's going to treat all cancer or rapidly treat all pain. And that's where intervention for these spinal fractures with implants and radiofrequency and cement, or cement and radiofrequency alone, is going to become more and more commonplace, I think. So you look over here, this is just a way of describing the way in which radiation is delivered to kill tumors, but the overall pain response, and that's what patients really are interested in, is how quickly can their pain be treated and whether or not their local disease can be controlled. But the overall pain response is seen in only about 2/3 of patients for either kind of delivery, and about 1/3 get total pain relief. So there's a very significant proportion of patients that they still have pain, and that pain can be adequately helped and treated by what we do. This is a patient with cancer. He had a cancer called hepatocellular carcinoma involving one of the lower lumbar vertebrae. This is just some measuring to see adequacy for the device to be used and placed. These are images throughout the procedure showing access of the needles into the bone. These are the ablation probes that we use. These ablation probes will heat up to a temperature that will induce death of cells in the vicinity of a very specified burn zone. And we use that to control the local disease. This is with the devices being placed. This is what it looks like under fluoroscopy. And again, you can see the Hyprevention B-strut device with this little black dot at its most distal point. These are just some other images showing, again, placement. It's a very straightforward procedure for people that work and live around the spine in day-to-day practice. It's nothing that's beyond the normal kind of scope of things that we do. And this is with the cement placed. And again, there's some follow-up data, which I don't have, which shows control of the tumor and nice stability of the lesion. This is just the last slide, and just talks a little bit about who's doing it. As I said, I'm an interventional neuroradiologist, so I come into this pool of interventional radiologists up here. There's about 8,000 of registered interventional radiologists in the United States who are registered with SIR, which is the Society of Interventional Radiology, with about 10% performing spine procedures. There are about 3,500 registered neurosurgeons through the match program system, with 20% doing vertebroplasty and the like, which is about 700. And again, pain physicians, which is a very rapidly growing field, with a smaller percentage of patients doing vertebral augmentation. But I think that's going to grow as the devices become easier to use, and the volume becomes such that they're just going to be necessary to treat all these patients. So I think that there's, in summary, a lot of growth in the field. I think that we have a toolkit which is getting better and better, but what we've got is a very complex anatomic structure in the spine, and not all fractures are the same and not all cancers are the same, and we need a bigger toolkit with smarter devices to approach individual fractures and devise bespoke treatments for patients, with the idea being that at the end of everything, we're decreasing the rate of adjacent level fractures and we're treating the patient's pain faster. But I think in the long run, we're going to be seeing more patients in the coming years, and certainly out in the next 5 to 10 years. Happy to take any questions. Obviously, I'll stop sharing now, and we'll go from there.
Yeah, my first question, Dr. De Leacy, is it looks like the characteristics of the materials is a key factor here. What's the ideal material characteristics you need to make this work?
So in any kind of device that you're putting into a patient, and it doesn't matter if it's a intracranial stent or a bone screw or bone cement, it needs to be as biomimetic and biocompatible as possible. And those are just jargon terms for saying it needs to replicate the tissue that it's being used to treat or replace. And historically, a lot of the implants that we've used that are used in orthopedic surgery and the like are metal-based compounds, which are excellent, but they don't have the same kind of flexomechanical properties that normal bone may or may not have. One of the things that I found really interesting in terms of this device, and the thing that initially drew me to it and wanted to have a look at some of the data that had been conducted, was how it replaced normal bone and tried to reinforce the structures in a more biocompatible way. And there has been some interesting and nice data done from engineering labs associated with Hyprevention showing how the PEEK implant compares to titanium implants, similar titanium implants. And the difference in the stress force applied to the vertebrae above or below with a replicated load is actually really quite impressive. You know, I came to this device because I had a problem and I was looking for a solution, and I have been looking for a solution for some time. And out of everything that came out there, and I try to use everything because we try to be bespoke and fit the right kind of solution to the right patient. This is the device that we came upon that seemed to have the most interesting way to approach tackling those representation adjacent level fractures. And anybody that deals with patients with compression fractures, the fundamental thing that patients and patients' family members do not understand is that it's a symptom of a bigger, more diffuse disease, and that's a metabolic disease, which is osteoporosis, and we can't cure that with a surgery. So when they come back 3, 4 out of 10 times in terms of patient numbers with more fractures at 1 month, 3 months, 6 months after treatment, they're always very frustrated, always very despondent and depressed that they think that their problem's completely solved, but it's not. So everything that we're moving towards in terms of treating these patients, and complementary medical management, aggressive management of their osteoporosis, but devices that are more designed and tailored to repair and replace and enact as normal bone as possible. And it's impossible to get to something identical, but we're getting closer and closer. And I think the new devices are the way to do it.
From a physician's point of view, how easy or how hard is it to actually install one of these?
It's the same procedural technique in terms of accessing the vertebrae that you would do with a vertebroplasty or a kyphoplasty. For interventional radiologists, we have a tendency to think smaller is better because that's just the nature. We don't do big incisions or dissections. So interventional radiologists take a little bit more of a conversation to convince them that a slightly larger access tube and a drill is going to be a better fit and a better use. But once they use it, and this is replicated with SpineJack from Stryker, it was the same phenomenon. People were a little bit concerned about the size of the device. And then they obviously used it. Patients were getting great outcomes. No complications were being seen by the access device. And it's taken off. And it's part of normal parlance for what we do in terms of treating fractures. Obviously, neurosurgeons, orthopedic spinal surgeons, they're not concerned about the size of the device. And it's essentially an identical procedure as placing a pedicle screw. So,
how long does it last? Is it for 10 years, 15 years, or must it be replaced at some point?
No, it's not a device that requires replacement. Once it's in, and it doesn't degrade within the lifetime of the patient.
Okay, great. If there's any questions in the audience, please post them there as well. One more question I had, and then we'll move to the presentation from Cecilia, is how long you've been working with these devices?
The V-strut specifically?
Yes, V-strut.
I can't actually put my finger on, but I'd say probably close to 24 months, somewhere between 18 and 24 months.
Okay.
Yeah.
All right. Very good. Thank you so much for that. With that, let's go ahead and move over and have Cecile talk about hypervention itself.
Thank you very much, Dr. De Leacy. So I'm going to share my screen. So Hyprevention has been created in 2010. I co-founded this company with orthopedic and spine surgeons, and the purpose of the company was to develop the strut plastic technology. The strut plastic technology aims to reinforce the bone when it is weakened by osteoporosis or cancer. And as you understood, we have now a product available in the US in order to address the vertebral fractures. So as Dr. De Leacy presented, the vertebral fracture can occur due to osteoporosis. So about 75% of the cases of the vertebral fracture will be due to osteoporosis. About 20% will be due to cancer. So that's really what we target. There is also another pathology. It's trauma fracture, and it's more low energy, high energy fracture. And with V-strut, we don't address this kind of fractures. So our device is patented in US and in other countries in Europe and all over the world. And in March 2020, we get the 510K clearance for this product. So it's available on the US market since then, but we really launched it in 2022. So this device, as we already said, is made of PIC polymer, and it is a combination of the PIC polymer implant with bone cement. And what makes this device is unique is that we have the pedicular anchorage of the device, and we try to reinforce the entire vertebrae. We already go through this, but just to remind you what Dr. De Leacy said is that our device is very promising compared to the competitors in terms of adjacent fracture prevention, and also in terms of techniques. The technique is very straightforward and easy to use. So that's why our device is promising. Regarding the team and the structure of the company, so the company was created in France, and today in France we do research and development, we manage the quality of the product and the regulatory affairs, and we also manufacture the product. And here in the US we have a subsidiary that is a Delaware C Corp, and we manage marketing, sales, and clinical studies. To develop the sales in the US, we have 4 business managers, one in Florida, one in Texas, one in California, and one on the East Coast. So we really are, we have our sales resources in the territories where you have the larger population. We also have a medical advisory board with Dr. De Leacy, of course, and Dr. Majid Khan from Johns Hopkins Hospital in Baltimore, and Dr. Cornelis from MSK Cancer Center. And the company has a strategic committee. So the strategic committee consists of 2 co-founders and 1 representative of our lead investor, Yellowstone. Yellowstone is a family office, so Yellowstone is part of the strategic committee. In terms of business model, so as I said, the products are manufactured in Europe and managed by the French company. Then the product is shipped to the US. We have a warehousing in Arizona where the products are placed in order we deliver our customers in the US. And our final users are all big hospitals like Mount Sinai or Johns Hopkins, but we also work with a surgical center or OBL. And we try to balance between the hospital and the surgical center OBL, because in an hospital, we have a very good reimbursement from CMS. So we have a pricing that is high, I will say, but the approval process is very long to enter a new innovative device in a big hospital. And when we work with a surgical center, the access is quicker because a surgical center are owned by the physicians themselves. So if they want it, they can buy it, but the reimbursement is very low. So for the same procedure, actually, the reimbursement is very low, so the pricing is very low. And we mainly do direct sales through our business development managers, and also using sales agent. So the sales agent have a commission, and their role is really to support the physician doing cases, attending the cases, and make sure that the material will be available for the cases, and manage the corresponding sales. In terms of roadmap, so in 2020, we get the 510K for VSTRAD. The year after, we get the reimbursement coding. And as I said, in 2022, we did our initial launch. Today, we are developing a device for the hip, and we are going to apply for the breakthrough designation to the FDA. This device is really a prophylactic device. It's to reinforce the hip and prevent the fracture. We have a clinical experience on this device in Europe with more than 100 patients treated in Europe. And the objective is to develop this product in order to introduce it in the US in 2026. And next year and the year after, we plan to have some enhancement of the VSTRAT in order to provide new sizes to the physician, because the feedback we have today from the field is that we could have a larger offer in terms of sizes, we could have a larger offer in terms of indications. So that's what we are going to work based on the feedback we have from the initial users. Why we believe we will be successful? So first of all, we have a really unique technology, as Dr. De Leacy explained, and not really any competitors to address as we do the adjacent fracture. Also, we have a very nice storytelling, because the SpanJack device that is owned by, now by Stryker was developed. Actually, I contributed to the development of this device. So we have a nice story to say that at Hyprevention, we are very experienced in product development, and it makes that the company is has a lot of credibility, because I had developed the SpanJack and now I developed the VSTRAT. And finally, as we explained, is we are working really on we are working on the largest indication. So we address the biggest market with osteoporotic and cancer fractures. In terms of achievement, so we have, as I said, we have patent, FDA reimbursement. We have more than 10 clients at the moment as hospital. We have more than 10 more that will become soon new clients with VAC approval in process. VAC approval is the approval process in the hospital. We have a network of distributors, so we really are expanding our network and also the resources to support the network of clients. This is, as Dr. De Leacy explained, a very, very dynamic market, and more patients will need to have a treatment. And today it is estimated that the market for percutaneous vertebral augmentation is about $500 million in the US only, and this number will double in 2030. So it's a growing market with a growing need for the patients. In terms of cash flow, so we had started to do to have revenue last year. We plan for more revenue this year, and our objective is to reach about 20 million revenue in 2027. And this year we have a cash burn of about $125,000. And of course, we will expand our team in order to reach these numbers. So our offer today, so to go to where we are today, we had about $9.6 million invested, mainly from business angels, and as I said, from a family office, Yellowstone. And now we are seeking for a new investment of 10 million. For our needs between this year and 2025, and we will have 3 tranches for this investment. So a first tranche of 2 million, and the objective of this investment will be to continue to develop the sales in the US, to make promotion of the product and train the new users, to make some enhancement of the product by adding sizes and by having a new indication approved by the FDA. And also we will complete a US National Post-Market Registry with the objective of 500 patients. We will have then in 2024 a tranche 2 for 3 million. And we will continue in this tranche to enhance the product, and also we will develop the hip product. And the third tranche of 5 million will be to continue the development of the sales development, but also to have international development of the company. As exit, we plan for an acquisition as 3 to 4 years for about 200 million. And this is based on our comparators. So as example, Stryker acquires a SpanJack developed by Vexim in France for 185 million. It was in 2018, and at that time, Vexim had about 18 million in revenue in Europe only, and just get the 510(k) approval. And there is another example. Boston Scientific acquired Vertiflex for almost $500 million with only the 510K. So this is a very dynamic market in terms of acquisitions. Actually, the model is that the innovative products are developed by small company and acquired by big companies that have the resources to deploy the product on the market. Thank you.
Great. Well, for those in the audience, if you have questions, please post them. My first question is how much do one of these procedures cost a patient or a hospital to perform? So
the patient, nothing. The hospital, as we said, we have the reimbursement. So when the procedure is done in the hospital, there is a reimbursement for the procedure itself, and there is also a reimbursement for the device. So the total envelope of reimbursement given by Medicare is about $10,000, but the cost of the implant will be more $4,000.
Okay. And for the intellectual property, what are the claims you're actually making on this device? What protection do you have at this stage?
So what is unique is the particular anchorage of the device, the use of these materials, the cement distribution in the vertebral body. So we have different claims that allow to protect our device. Yeah.
Great. And your distribution channel is direct, and also you have distributors. What's the division between those two? How much is direct and how much is going through your agent?
Actually, the direct means we sell directly to the hospital and we pay a commission to the agents. So the way we work is that our business development manager introduce the product in different hospitals, and then when the business has started, we have an agent that is going to do the follow-up. And sometimes, because we want that the business development manager develop another business in another hospital, and sometimes we have some sales agents that have their own network, and we take the advantage of their own network. So today it's really, I will say 100% done by the business development manager and supported by the sales agent.
Great. We talked about the exit being in 3 to 4 years. Do you foresee a potential where it could come earlier, given the value of the product and not just the revenue, but the value itself?
Yeah, so actually what the potential buyer are expecting, it's clinical data, make sure that there is a good acceptance of the product and make sure that the clinical results are appropriate. So that's why we work with Mount Sinai, doing study, registry, and etc. to really collect clinical data to show that the product is efficient and provide good clinical outcomes. And also what they are interested in is sales, in order to see that it's possible to have the product introduced in hospital and the product can be purchased by the hospitals. So we estimate that within 3 to 4 years, we will be in a position to show really that we comply with these 2 requirements.
Great. And Dr. De Leacy, if you can join us, can you tell us more about the clinical trials that are going on? How far have we gotten into it, and what are we finding so far in those results?
Well, there's essentially 2 arms to the clinical studies. One is the post-market registry that Cecilia was mentioning, where essentially all patients who've had the device placed in the United States, their available clinical data or easily available clinical data is being followed and tracked by us at Mount Sinai. That's actually been really quite interesting. We have some clinical research that we're about to submit for publication after some paperwork is done within our internal IRB, which shows essentially very, very as expected responses in pain to vertebroplasty. We're putting cement in, we're stabilizing the vertebral body. The rates of postoperative pain relief is exactly what we've seen in other patients that get standard kyphoplasty, and that's not what this device is about. But the rate of adjacent level fracture and refracture is much, much, much lower than the other devices that we've seen out there. So this is all post-market, essentially retrospective. So we're following it after the fact. The other arm is a prospective clinical study, which is of higher clinical value and clinical worth, where you follow patients from entry into a study beyond and contract them out to 6 to 12 months. That study is a multi-center prospective trial where we have 4 sites pegged, Mount Sinai being one, and the first site that's able to enroll. And we have 2 patients in that. We can't look at the data in that. It's not an open book. Those studies are only able to be reviewed once you finish a certain number of patients or you get to the end of a study. And that's a more impartial way to assess the, you're looking at pain data, but also impartially looking at the imaging data down the track with something called a core lab. So somebody who's completely unrelated to any of the procedures, just looking at the imaging to say, yay or nay, this patient's had an adjacent level fracture. Are there any issues with the device? So that is going to gradually, incrementally increase with more patients as they fulfill the entry requirements and as more hospital sites come on board. And we hope to have the 30 patients allotted in that trial well and truly enrolled or underway within 18 to 24 months.
So the total number of patients in each trial is 30, and how far are you into it so far?
So the total number of patients currently in the post-market registry is 38.
Okay.
And that is going to keep on climbing. There's no upper limit to that, but Cecile already mentioned the number 500, which is a great number. If we get there, that'd be wonderful. The prospective study is just 30. That's what's been allotted for, and it's essentially what we call a pilot study. We're looking to this to get some signal with really, really high quality data, and then springboard that onto something called a pivotal trial, where we look again with a finer microscope or a magnifying glass at larger numbers in a more prospective fashion.
Are there any other groups that are following this work and looking at the results of these trials? Anybody in the company world or the FDA world?
We're not sharing our data with any of the other large companies. This is separate. It's Mount Sinai. It's not funded or associated with any other kind of industry or corporation. It's purely about patient outcomes. And it's an important thing to be doing when you introduce a new product or a new procedure or a new device into the clinical setting. You need to have a QA/QI process, and that's essentially a big part of what this is. No doubt other clinical settings are going to be very, very interested in the outcomes. And that's the purpose of presenting our findings at clinical meetings. So we're about to submit to the American Spine Society meeting for next year, specifically with the post-market registry data. And depending on how many more cases we have by September of next year, then hopefully we'd go to Chicago to the North American Spine Surgery Association, NASS.
And what's next after this? Do you see follow-on versions of this that you would do continuing trials on, or is this it?
No, I think this is the wonderful thing about medicine and surgery and minimally invasive treatment. It's ever changing. There's always improvements around the corner. We can always do things better. This is, iPhone version 1, and I'm sure there are going to be other ones that come out that are smaller and easier visually to put in terms of smaller access channels. There's lots of different ways that we can build and grow upon this. But like I said at the beginning, you think of the spine and the fractures that we see, these are very, very complex anatomic and mechanical structures. And up until this point, we've had 1 or 2 devices and bone cement to really tackle the most complex biomechanical structure in the human body. So there's huge white space out there and opportunity to devise devices that are better than the predicates at treating the fractures that we have, stabilizing the spine and restoring anatomic function. Huge amounts of opportunity. And as you can see, it's the volume of patients out there that are being undertreated or not treated is nothing short of astonishing and from a clinician's point of view, disappointing.
Where would you like to see it go next? If there's many different kinds of fractures in the human body after the spine, where would it go?
Well, as Cecile showed, and it already has a history of it, prophylactic treatment of fractured neck of femurs. It's another epidemic fracture in the elderly, similar to spine fractures. Spine fractures can sometimes be a bit of a warning sign of frailty and immobility in falls. If you fall and you're, in a strange way to think about, lucky enough to just break your vertebrae, then that's a better clinical outcome, albeit very, very bad, than a fractured neck of femur. A fractured neck of femur in a patient over the age of 70 or 75 has a really quite higher than you might expect 12-month morbidity and mortality rate in these patients. So if you can prevent them from fracturing, then I think that's going to be, you know, a really, really impressive thing to be aiming for.
Great. Thank you for that, Cecilia. Did you have any closing comments at this point?
No, I'd like to thank Dr. De Leacy for giving all the expertise on the device and the field. No, thank you for the opportunity to present Hyprevention, and we look forward to receive feedback from the investors.
Great. Dr. De Leacy, did you have any closing comments, or did we cover it already?
No, thank you for inviting me. It's nice to talk about these things and to show the data and the experience that we have today. Hopefully it's helpful.
Well, it's quite an impressive feat to build something that can impact so many people and get such a strong reimbursement rate. It's clearly a priority of the FDA. If they give that much money out, that's going to be, or Medicare, that if you give that much money out, it's simply something that's required by the market. So it's very impressive what you guys have done there. I want to thank you guys for sharing that with us today. I want to thank everybody for coming in the audience as well. And with that, we'll go and wrap it up, and we'll look forward to seeing next steps. Thank you so much.
Thank you.
Thank you very much.
Thank you.